afternoon. Thank you, John, and the organizers for inviting me. We have been curing Hodgkin lymphoma for 40 years. First approach with extensive radiation therapy, in early stages with adjunctive chemotherapy. Following that, with chemotherapy, with adjunctive less extensive radiation therapy, and more recently chemotherapy only. The problem is the high rate of late mortality and serious morbidity related to treatment, particularly radiation therapy. So just a brief kind of history of the principles of Hodgkin lymphoma radiation therapy that really were put together nearly 60 years ago when these investigators, particularly Vera Peters in Toronto, but also Henry Kaplan at Stanford, Dr. Tubiana in France, and Eason in England showed that early stage Hodgkin lymphoma could be cured if you treated all involved and adjacent sites. Techniques were developed to be able to do this to very extensive fields. The extended field radiation therapy approach came into use with the advent of the linear accelerator, which Dr. Kaplan brought into clinical use. And subsequently, though, combined modality treatment using chemotherapy primarily with less extensive radiation therapy, so-called involved field radiation therapy, provided results with superior performance progression-free survivals as compared to the extended field radiation therapy alone in early stages in several randomized controlled trials. Never any difference in survival. Still, with this involved field radiation therapy, they still treated all initial sites prior to treatment. So, for example, if you get chemotherapy and most of the disease responds, there's just a few sites left, they still treat all the involved sites. So there have been various iterations of involved field radiation therapy through the years where they have decreased the post-treatment chemotherapy volumes. However, they still treat all the initial sites. And the most recent iterations of this are involved nodal radiation therapy or involved site radiation therapy. And again, all initially involved sites are still treated regardless of whether or not residual masses are found following chemotherapy. So this is my one picture is worth 1,000 words slide. So this is a summary of 40 years experience of all the trials conducted at Stanford between 1960 and 2006. The beginning era was that of extended field radiation therapy, again alone for early stage disease with chemotherapy as an adjunct in more advanced stages, subsequently with combined modality treatment with primary chemotherapy and adjunctive radiation therapy, bringing us really to the Stanford 5, which was the latest iteration of this combined modality approach. So what this shows is that this approach does cure the Hodgkin lymphoma. So most of the deaths due to Hodgkin lymphoma occur within the first 5 years or so, and then there's a plateau. So only about 18–19% of patients die of Hodgkin lymphoma. Relapses occur before patients die of disease, and again, they occur within the first 3 years or so, but after that there's a plateau, so about 30% of patients relapse. However, the overall survival at 40 years is only 25%. So these are patients who are at diagnosis between 25 and 30 years of age who are now in their 60s and 70s, and I think that the actuarial survival of this population is better than 25%. And most of these deaths are due to other causes. So this shows data from our own retrospective series of clinical trials that we conducted at Memorial between 1975 and 2000. They were all combined modality trials with the exception of one trial that had a chemotherapy-only arm. And what we found was, again, most of the deaths due to Hodgkin lymphoma occur within the first 5 years with a plateau after that. However, deaths due to other causes start to really pick up after 10 years. And at 22 years, deaths due to other causes exceed those due to Hodgkin lymphoma. This has just been published online in the Journal of the National Cancer Institute. So the causes, so again, here is the Hodgkin mortality. The leading cause of death in this population was second primary neoplasms, and followed by cardiovascular events, including stroke, early coronary artery disease, heart valve, fibrosis, and so on. I will mention that among the survivors, both second primary neoplasms and cardiovascular disease were serious causes of morbidity. So these are really causes of both mortality and morbidity. So no dose of radiation therapy is really safe. I didn't show a slide from the long-term follow-up in children using combined modality treatment in advanced stages with low-dose radiation therapy, doses around 15 to 20 gray. The incidence of second primary neoplasms was similar to that seen with more conventional doses. With respect to the heart, there clearly is no safe dose, and this is from breast cancer chest wall literature, looking at risk of deaths from ischemic heart disease and coronary artery events, with or without other risk factors, and either with or without risk factors, doses as low as 3 gray are associated with an increased risk of cardiovascular disease and mortality. So recently, not only have they developed new iterations of involved field radiation therapy, shrinking the treatment port, but there are new technologies which can also potentially somewhat also reduce the off-target effects. And so this is a summary of some of these. This is 3D conformal radiation therapy. This is IM, intense modulated radiation therapy, IMRT, and this is proton beam RT. So protons are particles. They don't go through the tumor like photons. And so with these, you can somewhat reduce the off-target exposure to other organs like the heart, lung, breast, thyroid, and esophagus. And this is really talking about combined modality treatment with mediastinal disease. But still, there is significant off-target exposure. So this is actually what they've published recently as the latest iteration of involved field radiation therapy, so-called involved site radiation therapy. This is using photons, and as you can see, the treatment volumes, all initial treatment sites are treated regardless if there's disease following the chemotherapy, and the results are still a substantial amount of off-target radiation given to worrisome organs. So I think that, using current techniques and concepts, they've really pushed this as far as they can. And we'll talk at the end of the talk about maybe some ways that you could possibly give radiation therapy when necessary more safely. So now I'd like to turn to some recent studies that I think establish chemotherapy only as a reasonable option. First, we'll talk about stages 1 and 2 non-bulky disease, and there are 2 trials that I'd like to just briefly mention. One is the HD6 trial conducted by the National Cancer Institute of Canada Clinical Trials Group and ECOG, which took patients with stage 1 and 2A, no stage B patients, excluded very favorable patients and unfavorable patients with bulky disease or intra-abdominal disease. The rest of the 1 and 2A patients were stratified according to risk factors. Again, these are risk factors sort of somewhat arbitrarily selected on univariate analysis: age, sedimentation rate elevation, histology, and number of sites. And patients were randomized to either experimental treatment with ABVD alone for 4 to 6 cycles, depending on their response, or conventional treatment, which in this trial was defined as extended field radiation therapy, usually subtotal lymphoid irradiation. In the favorable group with none of these risk factors, only radiation therapy, 2 sites of ABVD were added to the unfavorable group. The hypothesis of this trial was, and the primary endpoint was 12-year overall survival, a very courageous endpoint. There are very few trials that are designed to look at such a late endpoint, but I think a very important trial. Took 14 years to complete this trial, and I really give Ralph Meyer and his colleagues a tremendous appreciation and for their courage. So what they found is exactly what they thought. So overall survival for these patients was inferior for radiation therapy as compared to ABVD alone, due to deaths due to things other than Hodgkin lymphoma. An important, interesting finding, though, was that relapse rate was about 5%, 6% higher for chemotherapy only. However, the salvage of these patients is actually very effective. There's a second chance at cure. Patients who relapse in local sites initially involved can be treated with radiation therapy only, radiation therapy with chemotherapy, or radiation therapy and extensive chemotherapy with autologous stem cell transplant. The second trial is the RAPID trial, which was reported several years ago at ASH, and I think is probably percolating through submission and hopefully will soon appear. Again, this was a trial in stage 1 and 2A non-bulky, in which patients received 3 cycles of ABVD. They underwent PET scanning following that. PET scan is now the standard way of assessing response. PET negative patients have a 10% or less chance of recurring following treatment. False positives are more of a problem. So in this trial, if patients were PET positive with a possibly higher rate of relapse, they received an additional cycle of ABVD and then involved field radiation therapy. The patients who were PET negative were randomized to either involved field radiation therapy or no further treatment. So what this trial showed was no significant difference in progression-free survival, a slight advantage in favor of the radiation therapy. However, with respect to overall survival, again, no significant difference, but a trend toward slightly better survival for ABVD only. So I think these 2 trials, to me, kind of establish this as a chemotherapy only as a very reasonable approach. There is no evidence that adding radiation therapy improves survival, and there is evidence that radiation therapy, at least in the forms that it has been given, does decrease survival. So what about stage 2B? I think there's some controversy about this. Our own experiences, I'm not sure if you take into account other risk factors, that there's a big difference in prognosis between A and B, but some say that there is. This is an retrospective experience from British Columbia suggesting a higher relapse rate, maybe more like more advanced stages of disease. So in many clinical trials, bulky disease is included with advanced stage protocols. And I think for for me, I mean, if we can use 3 to 6 cycles, 3 or 4 cycles possibly for early stage disease, for advanced, for stages 2B or 2A, I tend to go with a full 6 cycles of chemotherapy, though there is really not, you know, there's really no data to really support that. So what about stages 3 and 4? Well, I think this issue was addressed very well in a clinical trial that was published over 10 years ago of the EORTC, fairly large trial, over 700 patients treated with the MOP-ABV hybrid, which is an adequate chemotherapy regimen with similar results to ABVD, but a higher toxicity, which was shown in a CALGB study. But anyway, adequate chemotherapy. Patients in complete response, which was 421 patients, were randomized either to involved field low-dose radiation therapy or no further treatment. The follow-up in this trial was fairly long. It was nearly about 6.5 years. Pretty good for such a trial. There was no statistically significant difference between the arms in patients achieving a CR, and by the way, this was by CT rather than PET, for relapse-free, event-free, or overall survival. And there was actually a trend toward a worse survival for the low-dose involved field radiation therapy. So this is at 6.5 years. I think it's very possible if this cohort would be followed that you might see a statistical significant difference with further follow-up. So what about stage 2B bulky? Stage 1 and 2 bulky. So this is the one place where I think combined modality treatment with chemotherapy and radiation therapy remains a standard of care. However, there is recent data, and not limited data, I would say, suggesting that there may be a subgroup of these patients who will not require radiation therapy. And this is very important because this is typically a very vulnerable group of patients for radiation damage, the young women with bulky mediastinal disease. So this is retrospective data from Vancouver, where they treated bulky stage 2, stage 3 and 4 with 6 cycles of ABVD. At the end of treatment, if there was a residual mass of at least 2.5 centimeters on CT scan, they did a PET scan. PET positive patients, they radiated. PET negative patients, they gave no further treatment, just as the patients who had no residual masses. So this shows that the patients who were PET negative with initial bulky disease had a similar outcome to those who were non-bulky and did not get radiation therapy. Other data comes from the HD6 trial of the German Hodgkin study group, which was for stage 3 and 4 disease and also stage 2B. This is considered to be advanced stage disease in their studies. This trial randomized patients to 3 iterations of the BA-COP regimen, and again, like in the Vancouver retrospective analysis, patients at the end of chemotherapy who had residual masses of at least 2.5 centimeters received PET scans. Patients who were PET negative received no further treatment, no radiation therapy, and patients who were PET positive received radiation therapy. So the top curves, and this was a very large study, this is typical of the German studies, so a lot of statistical power. The relapse, the progression-free survival for patients who did not have residual masses was the same as those who had residual masses who were PET negative. And this was the patients who had PET positive residual masses who had a somewhat higher relapse rate. So this suggests that patients who are PET negative at the end of treatment, even if they have bulky disease, may not require additional radiation therapy. So since this remains the standard of care, I have a discussion with my patients at the end of treatment. I say, you know, this is really kind of the standard of care, and the reason is that there may be a higher relapse rate if you don't get the radiation therapy, but we have this data, and I would be perfectly willing to follow you. I think we have excellent salvage treatment should you need it. And, you know, anecdote, which is worth nothing, but I have yet to have a patient relapse. But again, that's a complete anecdote. So radiation therapy does not improve survival. In fact, it may make survival worse. It may slightly reduce relapse rate. So question I think is very interesting is, can we limit radiation therapy and give it more safely when necessary? So there are a couple of approaches to this. One is already in progress. There are several trials using interim PET as a biomarker to tailor treatment. Interim PET has been shown also to have excellent prognostic value, as well as end-of-treatment PET, so that patients who are PET negative after 2 cycles of ABVD seem to have a 10% or so or less risk of relapse, whereas those who are PET positive after 2 cycles of ABVD may have relapse rates more in the neighborhood of 50% for early stage and maybe higher for more advanced stages. So there are a number of these trials in progress. Actually, none of them have really been reported in full form. These are 3 examples conducted by the cooperative groups. CALGB 50604, which I chaired, was an intergroup trial, and the data is completed. I went through all the cases 6 months ago, and I'm waiting anxiously for the statistical report. We will have an abstract for ASH and a publication on this. The Southwest Oncology Group 816, which was headed by Ali Press, again, intergroup for stage 3 and 4 disease. The manuscript has been submitted, and CALGB 50801 is headed by Ann Lacase at Dana-Farber, and is still accruing. So all of these trials are sort of complementary. They have a similar design. Patients get 2 cycles of ABVD and are then get a PET scan. In the early stage trial, PET negative patients get 2 more cycles of ABVD. PET positive patients, more intensive chemotherapy with escalated BA-COP and involved field radiation therapy. The patients with stage 1 and 2 bulky disease who are PET negative after 2 cycles get 4 more cycles of ABVD, a total of 6. PET positive patients, again, more intensive chemotherapy with 4 cycles of escalated BA-COP and involved field radiation therapy. And in the advanced stages, 2 cycles of ABVD and continuing chemotherapy for 4 more cycles, total of 6 for PET negative patients, 6 cycles of escalated BA-COP without radiation therapy for more advanced stages. So this may be a way of tailoring treatment to patients who need it. Another way another approach may be to give less extensive radiation therapy. So this is an actual patient who was treated by my colleague in radiation oncology, Dr. Kalan, who was a 20-year-old young man who had stage 2AX, bulky mediastinal Hodgkin lymphoma. He achieved a CR after 6 cycles of ABVD. That was PET negative, so he may not have needed radiation therapy anyway. So this is a involved site, the latest iteration of involved field radiation therapy, designed by Dr. Kalan using protons. So as you can see, still, as I showed you with photons in the published thing, a pretty extensive field. Unlike the photons stop at the tumor and don't go through it, but a very big field. So I asked Dr. Kalan, just as a thought exercise, design a clinical trial just to treat the residual mass. And this is what he came up with: a tiny port with a dose to the heart of less than 50 centigrade. So I think this may provide an opportunity for reintroducing radiation therapy, the advantage being maybe getting a little bit higher relapse rate more safely. I think this certainly, I wouldn't advocate this, but I think it's an opportunity that should be looked into. So how do I put it together? And again, this is my opinion. Stages 1 and 2 non-bulky. If there's a CR, I would use 3 to 6 cycles of ABVD, 3 or 4 most commonly, and stop stages. Again, we need to see whether the interim PET studies show an advantage to treating interim PET positive patients with radiation therapy. Stage 3 and 4, I would not give radiation therapy if there's a complete response. And stage 1 and 2 bulky, combined modality is still standard of care. There is data to support no radiation therapy if patients are PET negative following chemotherapy. And I think, you know, we're looking at limited, safer radiation therapy, either tailoring radiation therapy to a subpopulation who needs it using interim PET, or I think we could consider giving radiation therapy only to residual masses after chemotherapy and not all sites prior to chemotherapy that resolve with treatment. So I think I'm a little over. Thank you for your attention.